Good afternoon, everyone, and welcome to today's Fireside Chat. I'm Amna Hussein, the Community Outreach and Engagement Manager at the Masonic Cancer Center at the University of Minnesota, your host and moderator for the monthly Fireside Chats with the Office of Community Outreach and Engagement. The Fireside Chats are brought to you by the Office of Community Outreach and Engagement at the Masonic Cancer Center at the University of Minnesota. Our office serves as a vital bridge between the Cancer Center and communities across the state of Minnesota and beyond. Our small but mighty team is committed to reducing the burden of cancer by actively engaging communities and providing access to relevant knowledge on the latest in cancer research, prevention strategies, the importance of screening and early detection, treatment options, survivorship, and opportunities for clinical research. Each month, we host these fireside chats to share knowledge, raise awareness, and highlight the people and research driving change across the cancer continuum. March is recognized as Anal Cancer Awareness Month, a time to raise awareness and deepen understanding of a cancer that is often under-discussed, yet it is highly preventable and treatable when detected early. Because anal cancer is not talked about very often, there's still a great deal of stigma, misunderstanding, and limited awareness surrounding it. But we know that awareness matters, prevention matters, and early detection matters, which is why conversations like today are so important. Today's conversation will focus on what you need to know about anal cancer, including the risk factors, prevention strategies, symptoms that present, the screening options available, emerging research in the field, as well as efforts to improve awareness and access to care. To guide us through this important conversation, we are so incredibly fortunate and honored to be joined by Dr. Elliott Arsoniadis. I know I probably pronounced that name wrong, so apologies in advance. He's going to have to correct me a few times. But Dr. Arsoniadis is a colon and rectal surgeon.
You did perfect.
Amazing. We'll hopefully keep it going. But he is an assistant professor of surgery at the University of Minnesota, a research member at the Masonic Cancer Center, and he is also the founder and principal investigator of Save the Bottoms screening program, which is focused on advancing anal cancer prevention and early detection, particularly through innovative community-centered approaches. Dr. Arsoniadis completed his medical training at the University of Chicago Pritzker School of Medicine, his general surgery training at the University of Minnesota, and his colorectal surgery fellowship at Cleveland Clinic in Florida. He also earned a PhD in health informatics from the University of Minnesota. His clinical and research focus on treating and preventing diseases of the colon, the rectum, and the anus with special expertise in high-resolution anoscopy, a key tool that is identifying and treating anal precancers. When he's not performing surgery or writing grants to fund his research and Save the Bottoms, you can probably find him at the gym, at brunch. We love a good brunch, and also chasing his pug, Louie. But before I pass it over to him, I'm going to just cover a few quick housekeeping items. So today's Fireside Chat will be recorded, as they always are, and it will be posted on the Masonic Cancer Center's YouTube page by next week. Closed captioning is also available for this session, so you can turn that on by clicking the CC button that's located on the bottom of your Zoom screen. For University of Minnesota employees and spouses participating in the university's Employee Wellbeing Program, you can claim your 200 wellbeing points for attending today's Fireside Chat by completing the link that I'll drop in the chat shortly. We also invite you to engage with us throughout the session, so please drop any questions or comments that you have using the Q&A feature that is also located on the bottom of your Zoom screen. We also have some time carved out at the end to take some questions. So I'm going to stop talking now and hand it over to our guest speaker, Dr. Arsoniadis. Please take it away.
Thank you. Amna Hussein, for this invitation to present. Thank you to the community outreach team and all of the Masonic Cancer Center. Let me just move these things so I can see my slides. Does it look like a presentation about anal cancer on everyone's screen?
It looks beautiful.
Looks good. Okay. Well, thank you again. I went to the one place I knew where there would be a fireplace for this fireside chat. It's in the common room of my building, so we might have people popping in. I apologize in advance. I did try and wear my most Mr. Rogers-y sweater for this. Give it a cozier feel. I do have one disclosure. I do educational content for THD. There's the makers of the THD Procto Station, which is the platform I utilize for my video high resolution anoscopy. I really won't be discussing THD specifically or its products, but there will be a video that I took using their video anoscope. But I'm not here to sell you on that today. Yes, a little bit more about me. I am a colorectal surgeon. My practice is split between university and then the Minneapolis VA. At the university, I do have a niche focus in running the anal dysplasia screening treatment and surveillance clinic with my partner in crime, Elizabeth von der Marowitz. I, at one point, did a PhD in health informatics with somewhat of a focus on implementation science. A few years ago, I ran screening from health informatics and became interested in sexual gender minority cancer research, especially in improving screening rates in these populations. And as part of that work, I co-founded and am principal as investigator for Save the Bottoms community outreach and research enterprise, which has benefited a lot from the generosity of Masonic Cancer Center. So thank you again. So our roadmap for the next 40 minutes or so, and please stop me if a question pops up. This should be more of an informal conversation. So anal cancer, what is it? What are the new screening guidelines? And I will explain why I put them in parentheses, the word new in parentheses. What's the follow-up and treatment for people who screen positive? And then how do we promote screening through, fun and innovative ways like community event-based screening units? Okay, so what is anal cancer? That's sort of our first question. So March is colorectal cancer awareness month, and everyone's excited about the, third most common cause of cancer in men and women in the US, colon and rectal cancer. But this talk is not about colorectal cancer. Yes, you should get colonoscopies. That's what I'll say about colorectal cancer. This talk is about anal cancer. So we're not talking about the columnar epithelium of the colon and rectum and the 6 feet or so that it occupies. We're talking just about the 5 centimeters or so of squamous epithelium that is the human anus. I think of it as small but very expensive real estate, because anytime anything goes wrong in that area, people know about it. One might call it the Edina of the GI tract, or one might call Edina the anus of the Twin Cities. I don't know, depending how. If you're from Edina, just know that this is a huge compliment from a colorectal surgeon. All right, so anal versus colorectal cancer. Let's just go through some main differences and then kind of forget about colorectal cancer, at least for the day. So anal cancer affects the squamous mucosa of the anus versus the columnar cells of the colon and rectum. Okay, while colon and rectal cancers may be sporadic, familial, or related to some genetic syndromes, there's almost no family link or genetic syndrome known to predispose one to anal cancer. Rather, the vast majority of anal cancers are all related to prior infection with HPV, the human papillomavirus, and immunosuppression from things like HIV, or if one is a transplant recipient, can also affect the likelihood of getting anal cancer. Colorectal cancer is almost no link to HPV, but maybe it's connected to our diets. We don't know. While the treatment of colorectal cancer is mostly surgical, right now the treatment of invasive anal squamous cell carcinoma is actually mostly with chemotherapy and radiation. And while screening and prevention for colorectal cancer involve getting a colonoscopy and removing polyps before they turn into cancers, screening and prevention of anal cancer involves the unfortunately named anal pap smear and then follow-up high-resolution anoscopy for those who screen positive. That may seem a little familiar to people. in the cancer screening and cancer prevention community. And one might think of it as a similar analogous, no pun intended, to the screening and prevention we do for cervical cancer, also caused by HPV. The anal cancer prevention community is a lot younger than the cervical cancer prevention literature, and so a lot of what we've done has actually been based on prior work in cervical cancer. So anal squamous cell carcinoma, anal cancer. In 2024, for the first time ever, the American Cancer Society quoted over 10,000 new diagnoses in the US. And so this has been increasing since the late 1970s. And then in 2024 and in 2025, for the first time ever, there were more than 10,000 new cases in the US and about 3,000 deaths attributed to the disease. As I said before, human papillomavirus, HPV, is the causative agent. It was first described actually in the late 19th century. And up until that point, treatment was with a surgery called abdominoperineal resection, which basically is removal of the entire rectum and anal sphincter complex. So that leaves one with a permanent colostomy for the rest of one's life. In 1974, a colorectal surgeon, Norman Nigro, decided to shoot radiation at the anal cancers in a total of 6 of his patients. And he found a 100% removal of the disease with radiation and a small amount of chemotherapy. And with just that, N of 6, the Nigro protocol was born. And we've been using that as primary treatment for anal cancers really since the 1970s, with really not much change whatsoever. Abdominal perineal resection is still reserved for cases that are resistant to radiation or for anal cancer recurrences following treatment. Although it represents only 2% of GI malignancies, and only 1 in 500 lifetime risk in the average US citizen, the risk is much, much higher in some populations and is increasing. And this past Saturday, we celebrated Anal Cancer Awareness Day, the 21st of March. So the colorectal cancer community gave us one day in their month to celebrate the anus, which is probably commensurate with the amount of real estate we take up. So who is at risk for anal cancer? So there are some key groups that providers should really be aware of. Of course, the sort of platinum medallion quintessential population at risk are the MSMs, the men who have sex with men, and trans women who are living with HIV. So their risk of anal cancer, especially as they age, can go well over 100 per 100,000 patient years. To put that in perspective, currently, colorectal cancer in the general population is at about 50 per 100,000 person years, and cervical cancer at the time of the beginning of the pap smear for screening in the 1960s was at about 30 to 40 per 100,000, and is now thankfully much, much lower than that, but with very aggressive screening efforts. Other populations at risk, those living with HIV who are not MSMs or trans women. Both men and women living with HIV are at risk somewhere between 25 and 30 per 100,000 patient years. So not quite as high as the HIV positive MSMs, but still, relatively at risk, especially when compared to other cancers that we aggressively screen for, like colorectal and cervical cancer. Later analysis of some data by Deshmukh et al. Looked at MSMs and trans women not living with HIV. And as they age, they can near similar risks of anal cancer, around 30 per 100,000 person years as they reach age 60 and above. Women who've had prior gynecologic, either precancerous lesions or cancer, are at risk. So women who've had prior cervical disease, vaginal disease, or especially vulvar dysplasia or vulvar cancer are at risk. And really the women who've had vulvar cancer can be nearly 50 per 100,000 person year risk. So those are a special population that we need to consider. And then finally, solid organ transplant recipients. Because of the immunosuppression to keep those transplanted organs working, that unfortunately does convey a higher risk for HPV-related dysplasia, including anal squamous cell carcinoma. Men and women have an extremely high risk, somewhere between 25 and 50 per 100,000 patient years as we get to about 10 years out post-transplant. So again, another very high-risk population. So why should we screen? Obviously, the point of any cancer screening is to decrease deaths. But for anal cancer specifically, what we really want to avoid is not just deaths, but the morbidity associated with treatment. Unfortunately, radiation for anal cancer can have some pretty bad post-radiation effects that can leave people with bowel, bladder, and sexual dysfunction. The radiation, I've been told by radiation oncologists, does leave people a little bit more debilitated than, let's say, the radiation one would receive for something like prostate cancer or rectal cancer. And so because of the area that needs to be radiated to rid oneself of anal cancer, it does predispose one to a lot more post-radiation morbidity. We know that prior to turning into a cancer, pre-malignant lesions develop in the anus, and this is what eventually turns into anal cancer. And these pre-malignant lesions we term high-grade dysplasia. And these can be identified with a procedure known as high-resolution anoscopy. And when these pre-malignant lesions are found, they can also be ablated with electrocautery, so they can be removed with a little buzz of the cautery pen at the same time that they're discovered. So a little brief aside about high resolution anoscopy. So this is a procedure that I perform at the university, mHealth, Fairview, ASC, and CSC. My partner, Elizabeth von der Marwitz, pictured here in her sunglasses with Naomi J, is my counterpart who will do this in clinic for initial exams and for small lesions. She'll send me the ones that require the operating room if they are larger lesions that might be too painful to ablate in clinic. This procedure was actually first performed in the early 1990s by Naomi J, who was a nurse practitioner originally wanting to specialize in women's health. But she was at the University of California, San Francisco. Think back to your, history of medicine, HIV and the AIDS crisis were in full swing, but we had the first generation of highly active antiretroviral therapy coming out. And so people living with HIV were not dying of AIDS nearly at the same rate, and people started living longer, even for years, with HIV. But doctors in the areas with high rates of gay men living with HIV, like New York and San Francisco, also noticed a huge uptick in what used to be a very, very rare disease, anal cancer. Well, Naomi J, who had been spending her career thus far, examining women's cervices and getting rid of cervical dysplasia, knew that, anal cancer was related to HPV and thought, well, if we can find cervical cancer while it's still in its pre-malignant state and get rid of it, maybe we can do the same, with the anus. And so at some point in the early 1990s, Naomi J stuck a colposcope, which normally used for cervical screening, into a gay man's anus, and high-resolution anoscopy was born. Like colposcopy, it allows for a biopsy and destruction of lesions right then and there. You can do it in the operating room. You can do it in the clinic. Accreditation in this procedure has been somewhat of a moving target, and the data was not strong for it until about 3 years ago when the New England Journal of Medicine published the Anchor trial. People who do breast cancer research, rectal cancer research, they have to deal with hundreds of RCTs saying different things. But thankfully in anal cancer, there's just one randomized controlled trial that I have to memorize and it's this one. And so you just also became an expert in anal cancer just by listening to this talk. This was the results of the Anchor trial were published. It had been going on for 5+ years prior to that. And what it looked at was whether high resolution anoscopy with ablation, so with destruction of premalignant lesions, was protective for the development of cancer compared to high resolution anoscopy and no destruction of the lesion, just watching it. Okay, so ultimately about 4,500 people living with HIV, most of them men who have sex with men, some men who have sex with women, and some women, but all living with HIV, were randomized to treatment either with high resolution anoscopy and ablation, or the monitoring arm, which was just high resolution anoscopy alone. Ultimately, 9 in the treatment group had progressed to an invasive cancer, while 21 in the monitoring arm progressed to cancer. Unfortunately, even though these were somewhat low numbers, they actually did meet the threshold established before the trial by the Data Safety Monitoring Board. And since their threshold for difference had been met, the Data Safety Monitoring Board convened at some point in 2021 and decided to close the trial and offer treatment to all those who were in the surveillance alone arm. And so all of those people were then offered high resolution anoscopy with ablation. They certainly could have kept the trial going. Unclear if that would have been ethical and gotten maybe more impressive numbers. But they closed it when they met their threshold. And then about a year later, the results were officially published in the New England Journal of Medicine. And so here's a Kaplan-Meier curve showing that anal cancer risk decreased by 57% in the treatment arm. I think there are probably a lot of factors that in real life, high-resolution anoscopy with ablation decreases the cancer risk by a much higher percentage. I think you have to think about the monitoring arm was a pretty robust monitoring arm. They were still being monitored with high resolution anoscopy. They just weren't being, ablated. And so I think of, in the real life arm as people who aren't getting high resolution anoscopy, they're not getting ablation, they're not really getting anything. And then they just show up one day with what they think is a hemorrhoid to my office, and it's actually a stage 2 or 3 anal cancer, unfortunately. But that being said, this is what we have officially in the books as a 7% decrease in cancer risk, and these were published. So we know that HRA can identify and treat anal dysplasia, the premalignant lesion, and thus prevent anal cancer. I won't make you watch the entirety of this clip because it's a little long and we have 40 minutes. But this is a high resolution anoscopy. The very pink area of the mucosa is the rectum, and then the anal canal is the white portion that you see there. As you can see, I'm going through looking for areas that could be dysplastic. I'm going to go a little fast here. I see a bright white lesion right there. And so I paint it with Lugol's dye, and I see that it remains kind of more white and doesn't take up that Lugol's dye quite as much. And so I decide that that's probably dysplasia, and I go in, I numb it up with my little bee stinger needle, and I take a biopsy of it. Ouch. And then I go in, and because it's small enough, and this is an awake patient, I'm discussing it with them, as we're doing it, if they're comfortable proceeding, and they were. And so I proceed to ablate the lesion and burn it out, and it is gone forever. And it did indeed come back as high-grade dysplasia. So high-resolution anoscopy, it's not for screening. Okay, it's for treatment of people who screen positive, but there are only a few providers who do it. For instance, there are only 6 in the Twin Cities, and I would say that we are a very well-served community by having 6 providers. That's a lot. I'm going to plug this in while I'm still talking to because I see my battery is running low. But it's also difficult to learn. I spent over a year every Thursday afternoon in clinic with my then at the time boss, Dr. Robert Madoff, learning this procedure with him. And so this was not during fellowship. This was not during residency. This was during, my first year in practice. So I'm trying to balance, learning how to be an attending colorectal surgeon doing, colonoscopies, removing colons, all of that, and also trying to learn this new procedure so that when he retired in a year or two later, there'd be someone still left to do these. My nurse practitioner colleague, Elizabeth von der Marwitz, was also instrumental in helping me learn. But, this is not something that every colorectal surgeon can do. It requires, a lot of investment. And so it's certainly not what we can do as initial screening. That's not possible. So how do we screen then if we can't just stick video anoscopes into everyone's butt? A little bit, another aside, while we're talking about anal cancer screening, because it sounds sexy in grants and presentations, what I'm actually screening for and trying to find is that premalignant lesion, that dysplasia. And so really we're doing anal dysplasia screening, but that sounds nerdy, and anal cancer screening sounds cool. So that's why we still say it. Also, just a reminder, screening is for asymptomatic patients. If a patient is bleeding, if they feel a mass, if they're having pain, if they're having any anal symptom, they need their anus checked out and then referral to a specialist in anal rectal diseases. There are two methods to screen. One is the digital anal rectal exam, sort of the old school finger. Unfortunately, I think this can only find either very large high-grade lesions or an early cancer. But even those early cancers are still going to need that full brunt of radiation. So I don't think you're really getting, you're getting to cancers earlier, you're not finding dysplasia. I prefer the anal swab, which has two components. It tests for cytology, so cellular abnormalities, and then it also tests for high-risk HPV types. And depending on the lab, results may come back as, high-risk HPV present or not present. Our lab here at the university will speciate out each HPV type and then tell you if it's one of the 15 that are implicated in cancer. And then others will do more of a cervical style report where they'll say either 16, 18, or other high-risk positive. Just depends on your laboratory. The anal swab is not done with the cyto brush. Don't put that in anyone's anus because then they'll have to see me because they'll be bleeding. We use a nice soft Dacron polyester swab and then send it off in the BD SurePath culture media. Can stay at room temperature. It's good, I hear, for about 7 days. And then we can get results from the lab at that point. Also, whenever I counsel either providers doing this for the first time or patients who are going to be doing a self-exam, a self-test, I always remind them this isn't rectal cancer STI testing, where we're trying to reach the lower rectum. This is just reaching the anal canal. And so you really don't have to stick it, more than a centimeter or so into the anus itself. If you're here within mHealth Fairview, this is what the anal pap smear order looks like. I always say yes to adding on HPV testing, and then it should give you anus as a source for the order. Or if you just don't have time or the supplies or whatever your impediment, if you're at 909 Fulton, you can always send them over to the 4th floor to the colorectal clinic. We're easy to schedule either an MA or nurse visit for an anal swab. We can usually get people in same day, super quick to do that screening. If you're at 909 Fulton, there's usually someone there who's able to do it Monday through Friday, 8 through 4, 8 through 5. So who should be screened? Well, in 2024, the International Anal Neoplasia Society gave us the first comprehensive guidelines. Prior to that, there were a lot of societies that had some sort of recommendations that, were based on best guess. The HIV societies had some, the transplant societies had some, American Society of Colorectal Surgeons had some really bad ones, but none were, entirely evidence-based, and none were comprehensive. Okay, they were all sort of focused on their own little area of specialty. And so these were the first comprehensive anal cancer screening guidelines. And the NIH, HIV Medicine Association of the Infectious Diseases Society of America, and the CDC all adopted these guidelines. USPSTF did not end up reviewing this, and probably won't for at least another few years. Also, another adopter of the guidelines, American Society of Colposcopy and Cervical Pathology, adopted these, and then the Australian Society for HIV Medicine. I believe the French, in the meantime, have come up with their own guidelines, but don't worry about the French. Okay, so back to our infographic from Clifford and colleagues, my favorite infographic available on PubMed. Where did they decide to sort of draw the line? Well, they decided that anyone with higher than a 17 per 100,000 cancer risk would be considered category A. So the groups that we would really focus on during this initial implementation and dissemination of guidelines, while those with less than 17 per 100,000 were considered category B, and really more of a discussion between provider and patient. They came up with the number 17 because that is 10 times the risk in the general population, which is 1.7. And so in risk category A, you have the MSMs and trans women living with HIV who should begin screening with an annual anal swab at age 35, while those living with HIV who are not MSM or trans women, so women living with HIV and men who have only sex with women who are also living with HIV, those begin at age 45, while MSMs and trans women who are not living with HIV also begin at age 45. Women with prior vulvar precancer or cancer should be screened within a year of diagnosis, and then solid organ transplant recipients at about 10 years post-transplant. So what do we do with the results? So these can get a little hairy, actually, and a lot of it is based on access to high-resolution anoscopy. Unless I'm wrong, the vast majority of you are listening to us from in and around the Twin Cities, where we have at least 6, maybe 7 soon, providers who do high-resolution anoscopy. So we really, can go with the more conservative approach here as far as when to go to high-resolution anoscopy. Basically, if there's any cytology abnormality worse than ascus, they should go for high-resolution anoscopy. So HSIL, LSIL, or ASC-H, those guys should be sent for high-resolution anoscopy. Similarly, anyone with a high-risk HPV type should also be sent for high-resolution anoscopy. In areas where there is not as much high-resolution anoscopy or none available, there are some, more liberal guidelines that say, any high risk you don't send for HRA, but 16, the worst one, you do send for HRA, or stuff like that. But again, speaking to my Minnesota audience, we have the luxury of a lot of providers here, or a relatively large amount of providers, and so we can use a little lower threshold for what we consider a positive test. The one difference at the University of Minnesota that we do that's a little bit different than Ian's is there are some people who we will send for a high-resolution anoscopy, even with a diagnosis of ascus, atypical cells of uncertain significance, basically the least scary of the abnormal results you could get from an anal pap smear. If they're living with HIV, we will still do a high-resolution anoscopy on those people. And after a few more years, we'll probably look at our data and see if that makes sense or if we're just over-treating. If you have your phone handy, this is a link to the Ian's guidelines. You can read a much better worded paper than what I just spewed out at you in words. And if you don't want to read, you can just ask us. Elizabeth is available via email, phone, or Epic message, and she has excellent same day, usually same hour response times, Monday through Friday, 8 a.m. to 5 p.m. Just don't address her as Liz or Lizzie. She is Elizabeth. I'm also available. I'm kind of good at emails. I'm very good at texts. I'm notoriously bad at Epic messages, but I'm trying to get better. It's my 2026 resolution. But feel free to text or email at any time, weekday, weekend, night, evening, whatever. And I will try and get you an answer if you have a question about if you should screen a person, or once you do, if those results would be considered a positive or not. So the fun part. How do we get these people to screen? Well, we know that implementing any cancer screening guidelines are inherently difficult. Anal cancer screening guidelines, probably even harder. Comprehensive guidelines are new. We're talking about 2024 as the first time they were even published. And anal cancer is rare, 10,000 total in the US. It's increasing, high risk in some populations, but in general, it's rare. People living with HIV, gay men, trans women, and healthcare have not always gotten along. At one point, I would have said improving, maybe. I don't know. A different talk. And then finally, unless it's in your clinics, an asymptomatic anus is probably infrequently discussed. And so if it's not bothering them, the people may not bring it up. You may not bring it up as their providers. And so it brings another, barrier to implementing screening. So community event-based screening units. We know that mobile mammography was pretty successful. I think there's even like a mobile CT scanner for lung cancer screening. There's also prior positive data dating back 20 plus years that patients at risk are actually quite good at doing their own self-swab in clinic. However, there is no prior experience published in the literature about anal cancer self-swabbing at community events. And so in 2023, we hypothesized that LGBTQ plus events may provide a unique opportunity to raise awareness of and conduct on-site screening for anal cancer in gay men, trans women, and non-binary persons. And so in 2023, we hosted the first of our now 3-year running community event, which we called Save the Bottoms. When we're on site at Twin Cities Pride, we usually get 2 large tents and put them together. We offer on-site anal cancer screening. We prefer they do a self-swab, but if they prefer a clinician, we do have clinicians on site to do the swab for them. We send it on Monday morning after Pride for cytology and high-risk HPV testing here at the university lab. In 2023 and 24, we limited it to 18 years and above. To be more in line with the guidelines, in 2025, we started screening people aged 35 and above. And so not perfectly in line with the guidelines, but I wanted one standard age for those with and not with HIV. And so we chose to go with 35 and started that in 2025. All our participants were assigned male at birth and had no prior diagnosis of anal dysplasia, and they agreed to follow up with a high-resolution anoscopy if positive. And so here's a schematic of our problem in the lower right. We started with our recruitment team, which were usually community members, read friends from my gym, who volunteered to try and get people to come and do self-testing. If they agreed, they came and discussed with our research team from Surgery Clinical Trials Office, who went through the consent form as well as a pre-swab survey that they did on their phones. There were clinicians on standby to further inform them about why they were doing this test, what type of results they should expect, and what those results might mean and what follow-up care would look like. They then went into one of two private swabbing booths about the size of a dressing room at a store. And then they completed a post-swab survey on their phone. We took the samples to the lab within about 48 hours. And then the cytology and HPV subtyping was done. When those results were available, those who screened positive, so either abnormal cells detected or high-risk HPV or both, they got a phone call from me explaining the results and what follow-up care would look like. And then if they agreed, yes, they wanted to pursue follow-up care, one of our clinic nurses would give them a phone call to set up that appointment for high-resolution anoscopy, which was then performed most of the time here at the CSC by either Elizabeth or myself. So, not knowing if anyone would do this in 2023, we were floored to get 101 MSM and trans women screening. Most of them were actually younger than the age of 35, but 43 were above the age of 35. In 2024, we invested in a fancier facade and more outreach prior to our event, and we got 144 to screen. And at this point, 81 of them were above the age of 35, so at least a little more than half this time. I was pretty worried going into 2025 when I said, okay, we need to be in line with the guidelines, kind of, this time. We're only doing it age 35 and above. Really worried, would this be, the thing that killed, my community outreach event? But to our great delight, 106 people underwent on-site screening, and they were all above age 35. And so our reach within that older, higher risk demographic has grown with each subsequent year. Surprisingly, maybe not surprisingly, these people were good at their self-swab. Most of them had a satisfactory sample. To put this into perspective, a clinician performing the swab in clinic only has about an 80% rate of a satisfactory sample, me included. And so this is not far off from what clinic standard would be. In 2023, 13% people screened positive, and then in 24 and 25, 27%, and then 31% screened positive. So an increasing number. It's interesting in 2024, we got about almost 2/3 of those who screened positive to get a follow-up HRA. Thus far, only about 52% of our positives have gone for HRA, but there are 3 pending HRAs that are still supposed to happen between now and the end of April. So that number should go up slightly. Interestingly, both years had about just a little under 25% of those who screen positive end up having a high-grade lesion. So HSIL is that high-grade dysplasia, that thing we're looking for and wanting to ablate. And again, subject to change, there are 3 high-resolution anoscopies still pending for our 2025 cohort. So when we surveyed these people, greater than 60% didn't even know they were at increased risk, and well over 80% had no prior screening or had discussed their risk with a provider. Interestingly, almost a vast majority had never heard of us before until they passed by the unit. Each year, this number decreases slightly, but still, for the most part, we're getting people, right then and there hearing about us for the first time, making that spot-on decision. They're not, coming to Pride with the intent of doing anal cancer screening. 1 or 2 of them. 93% would screen again and would recommend to a friend. So they found it pretty acceptable. And so going again to our schematic of our workflow, I really want to focus for the last few minutes on this right here, the part where the test comes back positive and we need to get them to high resolution anoscopy. And so looking at this is for 2025 alone, we had almost 75% of them complete it satisfactorily. And so a few lost to an unsatisfactory sample, not atypical. Of those 33 positive, That was 31% of the total swabs. So almost a third were positive in some way. I made a lot of phone calls, but I had 28 phone conversations, I should say. There were 5 people I was unable to reach, and I make at least 3 attempts to try and reach these people via phone. Of those 28 people whom I reached, 29 scheduled a high-resolution anoscopy at our clinic, 3 scheduled at other institutions, and 1 positive went back for redo anal pap with his primary care provider, and it was negative, so high-resolution anoscopy was not performed. And then 5 were lost to not being able to contact. So even though I had a conversation with them, they really were not reachable by our clinic nurse coordinators. Of those who went, who scheduled a high-resolution anoscopy, there were 17 performed, 15 here at the U and 2 at other institutions. And of these, 8 came back with high-grade dysplasia. 6 patients had low-grade dysplasia, but no high-grade. And then 3 scopes were negative. Again, this is not atypical. 1 patient did not show up to his appointment. There are 3 still pending at the next week and the weeks following here at the U, and then 1 had his done, or at least said he was going to have his done out of state, but we were not able to come into contact with him again. So looking at those phone calls, I just want to point out this is a big time investment. This isn't a 1 or 2 minute phone call. These ranged between 7 and nearly 17 minutes in length. And this is something I did, for 28 of these patients. The average length was almost 12 minutes for this phone call to really explain what these results meant and, what follow-up care looked like. I made little notes to myself about common themes, concerns, and questions that these people were coming up with. A lot of it, focused on practical things like insurance and whether or not this was covered or not. While our screening at Pride is free, because high-resolution anoscopy is considered standard of care, it's not an experimental procedure. Their insurance was charged, or in some instances, we did find them coverage through Minnesota MA. A lot of people had mentioned that they had received the HPV vaccine or were confused why it still happened, even though they had been vaccinated. A lot of people were angry this hadn't been found at their colonoscopy, and I had to explain, no, colonoscopy, we're looking at things that are visible to the naked eye. Here we're looking for things that are really microscopic. And there was a lot of confusion with other sexually transmitted infections, a lot of stigma and concern about whether they should keep having sex or whether they should have their partners tested. That was a concern. And then some actual real insightful questions about, if this meant they could get cancer elsewhere, stuff like that. So really all over the board here. So our conclusion from this experience, which was funded by an MCC community catchment grant, was that on-site anal cancer screening at LGBTQ plus community events is feasible, acceptable, and shows preliminary efficacy. And self-swabbing is promising even in non-traditional settings, but certainly the follow-up rates for positive tests need improvement. Clearly, there's a lot of cost and financial stress that was voiced by our participants. I think in next iterations of this work, which may be showing up on the application desk of the MCC Community Catchment Grant Committee in the coming weeks, is identifying the needs for positive screens to better understand the meaning of their results and what follow-up care is and looks like and is meant to accomplish. I think there's a huge knowledge gap and understanding gap, and rightly so. No one has been told to think about this, in their life. And so, we're really trying to do things to bring people from almost zero knowledge to, becoming miniature experts about their own conditions and diseases and problems. So it's not easy. So I think, a preliminary needs assessment to look at what sort of um, educational tools would be helpful to reach this population, and what really are their needs would be, I think, the next steps for a lot of this work, and at least our initial attempt at trying to improve that, 50 to 60%, more towards like 80 or 90. Um, and so that's my little soapbox about that. I am interested in bringing digital tools in to help better inform patients. And so informatics may in fact be rearing its ugly head. Our other step, we have introduced the at-home test kit, which is currently being piloted in some of our clinics. And so if you are a patient at Red Door, the Minneapolis VA infectious disease clinic, or our infectious disease clinic here at M Health Fairview at the CSC, we are offering an at-home test kit option for testing, and that pilot just started earlier this month, and we have consented our first two, I'm proud to say, so hopefully more soon. And so, brief summary: anal cancer caused by HPV, it's increasing, 10,000 plus last year and the year before. High resolution anoscopy can treat precancers of the anus and prevent progression to anal cancer. Absolutely screen your MSMs who are living with HIV starting at 35. Those with HIV who aren't gay men, or those who are gay men without HIV, start them at age 45. Women with vulvar, precancer, or cancer, and solid organ transplant recipients. That first vulvar dysplasia within a year of diagnosis, solid organ transplant patients at 10 years post-transplant. Any cytologic abnormality or high-risk HPV, send them over. And then community events are feasible and acceptable, and we will still continue to do them. But our follow-up of 50 to 60% needs to be improved. And I think that helping patients understand this disease and its treatment better is the key to solving at least some of those problems. So thank you, everyone, for attending and for being pro-anal, especially this month and every month. Thank you to the Masonic Cancer Center and the Community Engagement and Outreach Office, especially for that grant 2 years ago that really made our small efforts in 2023 blossom into a lot more meaningful work in the subsequent 2 years. And then if you want to visit our website and follow our socials, the Instagram is the most monitored one, but we now have 3 YouTube videos up, I'm pleased to say. And so follow us on our socials as well. All right. I've probably gone too far, but if there are any questions, I have all afternoon, but I know you guys all have probably important things to do, but I can stay on as long as needed.
Thank you so much, Dr. Arsoniadis. Did I say it correctly?
Perfect.
Amazing. So thank you so much for the incredibly informative presentation, for breaking it down and shedding light on a topic that just does not get the attention that it deserves. And I really will just plug your website. It's absolutely beautiful. I dropped it in the chat. Check it out. Follow Save the Bottoms on social media, because the work is just beginning. But I do want to thank you for shouting out my city, Edina, comparing it to the anus as a small but expensive piece of real estate. That got me chuckling. But on a serious note, I really appreciate the way that your work pushes us beyond the clinic, and to consider how outreach, education, and community-based strategies play such a vital role in improving access and outcomes to care. So we have, I'm going to say, a minute to take questions. So let's see if anything has come through. If not, head over to the Save the Bottoms website. I know that there is contact information, so you can reach out to the team if you have any follow-up questions. And Dr. Arsoniadis has also provided his email address, so feel free to reach out to him if you have any lingering questions. But I guess I'll just ask one question. What has been the surprising findings or lesson learned from your community-based outreach? So from launching a program like Save the Bottoms.
I think the big takeaway, the big question we asked first year was, will people do this or not? And I'm so surprised that people will take time out of what's supposed to be just sort of a fun, joyful weekend and be like, oh, I'm going to do a cancer screening right here on site. Like it is simple, but it's also very private. Like they're sticking a swab into their own, anal canal, right there in Loring Park. I mean, in private tents, but still.
Mhm.
Um, I am impressed that people were willing to do this and that spurred on the next work. The other thing that I didn't think about at all beforehand was how confused people can get with other things that may involve their anus. I've had, a lot of older participants were confused that their doctor had checked for this already, but when you pushed further, it was actually, a digital exam for prostate cancer that they were talking about, or they thought this was something that was looked at by using a colonoscopy. That's a frequent occurrence. And then, not so surprising, a lot of people confuse this with colorectal cancer. And don't really think of it as a completely separate, organ and separate disease with its own risk factors. So those were all some very surprising and some not surprising, findings when you talk about this with people.
Yeah. And just following up on that, what advice would you give then to programs that want to expand cancer screening and want to design some community outreach efforts that are truly community centered and effective?
Make it fun and make it fun and colorful.
I love that. And just
Choose
the
a,
important,
choose an inviting color palette.
yes. And just the importance of meeting people where they're at, right? Like showing
Yeah,
up in spaces that you won't
yeah,
typically see cancer screenings
right,
being offered. And so that's really, really vital. And it is an
right.
effective community based strategy. So kudos to your team and all of the efforts and the work that you're doing. There was a question that was dropped about what is the best way to get your work known and also connected with the Minnesota Department of Health prevention efforts. I think
So,
forums like this
question.
and
Yeah.
continuing to spread the word.
Tell me the answer. I don't know. Tell me the answer to that. Tell me the answer to that question. They did not teach me that in informatics or surgery school. So if anyone has that answer or even a suggestion, let me know.
But I'm continuing to show up, partner with organizations, getting the
Yeah,
word out there. I
right.
think even just launching the mailed screening program as well is a way
Mhm.
for folks to start
Yeah,
spreading just the access and the availability of being able to and the accessibility of providing these screening options. So word of mouth is really important. And I think you said the trends increase in terms of awareness about the program
yeah,
in subsequent years being available at Pride.
right.
But we're going to wrap it up here. I'm so sorry, everyone, if you had questions that we were not able to get to. But before we wrap up, Dr. Arsoniadis, I'd love if you could just leave us with one key takeaway. What do you want our audience to remember from today's conversation?
Anal cancer is different than colorectal cancer. And if you have patients that you know are in those, 3, 4 demographics that we discussed, if you just mention it to them, it would be amazingly impactful.
Okay, there you go. Thank you again, Dr. Arseniades, for sharing your expertise and the important work that you're leading in the space. But before you log off, folks, just a few quick things to close us off with. We would greatly appreciate if you could take the time to complete just a very brief survey. It will auto-populate as soon as you exit out of the Zoom webinar, and then also we'll be linking it in the follow-up email that will go out tomorrow. Your feedback really does help us continue to strengthen the series, but also to bring you timely and relevant topics. And then, as a small token of appreciation for your time, you can enter into a drawing to win a prize pack filled with goodies from the Masonic Cancer Center. And we also hope that you join us for our next Fireside Chat on Thursday, April 16th, same time, same place. Today, we talked a lot about awareness, prevention, and the importance of screening. For our April session, we'll take it one step further and explore what actually moves people to take action on that knowledge. We'll be joined by Dr. Alex Rothman, a social and health psychologist at the University of Minnesota, who will share insights into how people initiate and maintain health behavior change and what it takes to turn awareness into action in support of better health. And if you'd like to stay connected with us, be sure to follow the Masonic Cancer Center as well as Save the Bottoms. You can see all their social media handles still on the screen, but follow them on all their social media platforms. And also be sure to follow the to subscribe to the Masonic Cancer Center's Community Matters newsletter to stay up to date on events, announcements, and community programs from the Office of Community Outreach and Engagement. Thank you again for spending your afternoon with us. We appreciate your time and engagement and look forward to seeing you next time. Bye now.